Studies have reported that response to antidepressants begins to outpace response to placebo only when symptoms are no longer mild. Using antidepressants for patients with mild depression could therefore place them at risk of overtreatment. I'm Dr. Suma Chand, psychologist, professor, and director of the Cognitive Behavioral Therapy program in the Department of Psychiatry, St. Louis University School of Medicine.
Welcome to the 20th episode of the MD Edge Psychcast. Today, Dr. Chand discusses the evidence that supports the use of cognitive behavioral therapy as monotherapy, as well as in combination with antidepressants for acute and long-term treatment of depression. And later, Dr. RK wants you to embrace the suck. And now, Dr. Suma Chand.
Major depression has a devastating impact on individuals and society, both because of its high prevalence, its recurrent nature, its frequent comorbidity with other disorders, and the functional impairment it causes. Compared with other chronic diseases, major depression produces the greatest decrement in health worldwide. According to reports from the World Health Organization, depression is the leading cause of disability as measured by years lived with disability, and the fourth leading contributor to the global burden of disease. Today, it has become imperative for the goal in treating major depression to be not just that of reducing symptom severity, but also to achieve continuing remission and to lower the risk for relapse. Antidepressants are the most common treatment for major depression. Among psychotherapies used to treat major depression, cognitive behavioral therapy, or CBT, has been identified as an effective treatment. I will be talking about evidence supporting the use of CBT as monotherapy and in combination with antidepressants for acute and long-term treatment of major depression. In the case of mild major depression, research has indicated that antidepressants are unlikely to be more effective than placebo. Studies have reported that response to antidepressants begins to outpace response to placebo only when symptoms are no longer mild. Using antidepressants for patients with mild depression could therefore place them at risk of overtreatment. In keeping with these findings, the American Psychiatric Association has recommended the use of evidence-based psychotherapy such as cognitive behavioral therapy as an initial treatment choice for patients with mild to moderate major depression. Earlier depression guidelines suggested that psychotherapy has no role to play in the treatment of more severe depression, and pharmacotherapy was recommended as the main treatment of choice for more severe depression. This recommendation was influenced by the well-known National Institute of Mental Health Treatment of Depression Collaborative Research Program, a multi-center randomized controlled trial that used a placebo control. In this study, CBT was compared with antidepressants and found to be no more effective than placebo for the more severely depressed patients. However, this finding was not consistent across 3 sites where the study was conducted. At the site where CBT was provided by more experienced therapists, patients with more severe depression who received CBT fared as well as patients treated with antidepressants. A later double-blind randomized control trial that used experienced therapists found that CBT was as effective as antidepressants, and both treatments were superior to placebo in reducing symptoms of atypical depression. Another placebo-controlled randomized controlled trial conducted at 2 sites found that CBT was as effective as antidepressants in the treatment of moderately to severely depressed patients. As in the NIMH Treatment of Depression Collaborative Research Program trial, in this study, there were indications that the results were dependent on therapist experience. These findings suggest that the experience of the therapist is an important factor. A recent meta-analysis of treatments for the acute phase of major depression compared 11 randomized controlled trials of CBT and second-generation antidepressants. It was found that as a first-step treatment, CBT and antidepressants had a similar impact on symptom relief in patients with moderate to severe depression. Patients treated with antidepressants, however, had a higher risk of experiencing adverse events and discontinuing treatment because of adverse events. However, this meta-analysis included trials that had methodological shortcomings, which reduces the strength of these conclusions. Patients with major depression and comorbid personality disorders have been reported to have poorer outcomes regardless of the treatment used. Forney et al. Examined the impact of antidepressants and CBT in treating moderately to severely depressed patients with and without personality disorder. They found that a combination of antidepressants and CBT was suitable for patients with personality disorders because antidepressants would boost the initial response and CBT would help sustain improvement in the long term. Presently, the APA suggests that the combination of evidence-based psychotherapies like cognitive behavioral therapy and antidepressants may be used as an initial treatment for patients with moderate to severe major depression. I will now move to talking about the role of CBT in the long-term treatment of major depression. Recurrence and relapse are major problems associated with major depression. The large majority of individuals who experience an episode of depression go on to experiencing more episodes of depression, and the risk of recurrence increases after each successive episode. To reduce the risk of relapse and the return of symptoms, it is recommended that patients treated with antidepressants continue pharmacotherapy for 4 to 9 months after remission. It is standard treatment for patients with chronic or recurrent major depression. However, the preventive effect exists only while the patient continues to take the medication. Rates of symptom recurrence following medication withdrawal are often high regardless of how long patients have taken medications. Studies have examined CBT as a maintenance treatment provided alone or in combination or sequentially with antidepressants and found that it has an enduring effect. The impact has been found to extend beyond the end of treatment and equals the impact of continuing antidepressants. A recent meta-analysis of 10 trials where CBT had been provided to patients after acute treatment found that the risk of relapse was reduced by 21% in the first year and by 28% in the first 2 years combined. Studies have compared the prophylactic impact of maintenance CBT and antidepressants. In an early study, 40 patients who had been successfully treated with antidepressants but had residual symptoms were randomly assigned to 20 weeks of CBT or to clinical management. By the end of 20 weeks, patients were tapered off their antidepressant medication. All patients were then followed for a 2-year period, during which time they received no treatment. At the end of 2 years, the CBT group had a relapse rate of 25% compared with 80% in the antidepressants group. Weaknesses of this study included a small sample size and the fact that a single therapist provided the CBT. The study was later extended to a 6-year follow-up with antidepressants being prescribed only to patients who relapsed. The CBT group continued to have a significantly lower relapse rate of 40% compared with the antidepressant group, which had a 90% relapse rate during the 6-year follow-up. In another randomized controlled trial, patients with depression who had recovered with CBT or medication continued with the same treatment during a maintenance phase. So the CBT group received 3 booster sessions during the next year, and the antidepressant group received medication. At the end of the 2nd year, without CBT or medication, CBT patients were found to be less likely to relapse compared with the antidepressant group. The adjusted relapse rates were 17.3% for CBT and 53.6% for antidepressants. A randomized controlled trial that included 452 severely depressed patients used a long intervention period of up to 42 weeks and a flexible treatment algorithm to more closely model the strategies used in clinical practice. Patients were randomly assigned to antidepressants alone or in combination with CBT. At the end of 12 months, outcome assessment by blinded interviewers indicated that patients with more severe depression were more likely to benefit from the combination of antidepressants and CBT, 76.9% versus 60.3%, and those with severe non-chronic depression received the most benefit, 79.5% versus 62.8%. The lack of a CBT-only group limits the generalizability of these findings. Neither patients nor clinicians were blinded to the treatment assignment. This is a common limitation in psychotherapy studies, but could have contributed to the finding that combined treatment was more effective. Some evidence suggests that augmenting treatment as usual with CBT can have a resilient protective impact that also intensifies with the number of depressive episodes experienced. In a randomized controlled trial, 172 depressed patients in remission were randomly assigned to treatment as usual or to treatment as usual augmented with CBT. The time to recurrence was assessed over the course of 10 years. Augmenting treatment as usual with CBT had a significant protective impact that was greater for patients who had more than 3 previous episodes. Another long-term study assessed the longitudinal course of 158 patients who received CBT medication and clinical management or medication and clinical management alone. Patients were followed up for 6 years after randomization. Researchers found the effects of CBT in preventing relapse and recurrence persisted for several years. Studies that have examined the efficacy of adding CBT to antidepressants in the continuation and maintenance treatment of patients with major depression disorder have had some limitations. The definitions of relapse and recurrence have not always been clearly delineated in all the studies. This is important because recurrence rates tend to be lower, and long-term follow-up would be needed to detect multiple recurrences so that the incidence is not underestimated. In addition, the types of CBT interventions utilized has varied across studies. Some studies have employed standard interventions such as cognitive restructuring, while others have added strategies that focus on enhancing memories for positive experiences or interventions to encourage medication adherence. Despite these limitations, research has shown promising results and suggests that adding CBT to the maintenance treatment of patients with depression with or without antidepressants is likely to reduce the rate of relapse and recurrence. To sum up, research indicates that cognitive behavioral therapy can be the preferred treatment for patients with mild to moderate major depressive disorder. Treatment protocols that utilize CBT plus antidepressants are likely to be more effective than CBT or antidepressants alone in the case of more severe depression. Incorporating CBT in the acute phase of depression treatment with or without antidepressants has been found to have a long-term beneficial impact. For maintenance treatment, CBT alone and CBT plus antidepressants have been found to help sustain remission. Thank you.
A big thank you to Dr. Chand. It's now time for Dr. Rene Kochanski.
Thank you for the introduction, Nick. Part of our work is helping our patients gain a different perspective on perhaps the same situation or struggle they've had for maybe years. Oftentimes we help soften their view or ease a harsh superego. The flip side of this coin is helping our patients cope with devastating events that are just a part of living. Hi, I'm Dr. Rene Kochanski for the MD Edge Psychcast, and sometimes everything is simply not okay. People lose their jobs and are faced with looming mortgages and no immediate viable prospects. A long-term meaningful relationship ends. A person's reputation is falsely and utterly, completely destroyed. an illness, injury, or accident, and maybe even the worst of all worlds, a parent must bury their child. We do no service if we say everything is okay. We can't fix it, and maybe neither can they, not at that moment. What there is to do is to sit in the reality of the situation with our patients. And that, my colleagues, is part of the power of our work. We stay present with our patients in the present. We acknowledge the truth and the awfulness of the moment. I borrow strategies from all sorts of places. In instances such as this, if it's appropriate, I'll share a line from the book Kaboom, and that line is, quote, "Embrace the suck." Now, what does that exactly mean? Well, to be able to sit in the silence and sadness of the moments. We don't change the situation, we don't minimize, and we don't problem solve. And we needn't experience the circumstance of our patient's specific trouble to understand their pain. That being said, after some time has passed, this might be a rare occasion where personal sharing is appropriate, where knowing we have personally been there might have extra import for our patients. Before considering this path, though, be extremely clear that you are acting in the interest of your own patient and not unloading a burden of your own. This technique is only for the skilled clinician and must be thoughtfully deployed. To even begin to utilize this strategy, you need to be absolutely clear that you are resolved and complete about whatever issue it is that you are about to share. Now, there will be time for problem solving, strategizing, analyzing, and all the other technologies we bring to treatment. But in the acute aftermath of something awful, don't just do something, do nothing. But really what I mean is just be present with your patient and help them find their way to, quote, embrace the suck. I'm Dr. Rene Kochanski for the MD Edge Psychcast.
And that concludes the 20th episode of the MD Edge Psychcast. We'd like to thank Dr. Suma Chand for stopping by, and we'd like to thank you for choosing to spend a few moments of your day with us. You can hear the Psychcast each and every week at mdedge.com/psychiatry, and you can subscribe wherever you get your podcasts, including Spotify, Apple Podcasts, Google Podcasts, and Amazon Alexa. For Dr. Chand, Dr. Kochanski, and all of us here at MD Edge, I'm Nick Andrews, and this is the MD Edge Psychcast.